Hi, and welcome to the MedTalks webinar series where you can learn from entrepreneurs, industry experts, healthcare professionals, and scientists who are driving progress in healthcare across the globe. I'm Andrew Adaby, and in this episode, we're joined by our guest, Dr. Stevie Laitner. He's a GP, he's a freelance health consultant, he's an advisory board member, and he's also trying to get better at multiple sports with some limited success. In this episode, we're focusing on the recent Stocktake Report, commissioned by Amanda Pritchard, written by Dr. Claire Fuller, Chief Executive of Surrey Heartlands ICS. The title is Next Steps for Integrating Primary Care, the Fuller Stocktake Report. I will start with an extract from the report, and I quote, "Inadequate access to urgent care is having a direct impact on GPs' ability to provide continuity of care to those patients who need it most. In large part because of this, patient satisfaction with access to general practice is at an all-time low. Despite record numbers of appointments, the 8 a.m. Monday morning scramble for appointments has been now synonymous with patient frustration. At the same time, primary care teams are stretched beyond capacity, with staff morale at a record low. In short, left as it is, primary care as we know it will become unsustainable in a relatively short time." Stephen, great to have you today. How are you?
I'm good, thank you, Andrew. Yeah, good, and good to talk to you.
Thank you very much. The statement I read out earlier gave a quite a stark impression, keen to jump straight into the discussion. Now, Dr. Fuller proposes a shift from siloed care to integrated teams at a neighborhood level. Now, what specific challenges you see or inefficiencies have there been that actually inspire this model?
Well, I think the first thing to say is that there's not a one size fits all to meet the needs of the population. And I think historically, general practice has been a bit of a one size fits all model, traditionally based on a 10-minute appointment with the GP. And I'm pleased to say we've moved on from that. We've got clinical triage up front, sometimes just taking a few minutes. All our face-to-face appointments in the surgery are now 15 minutes with a GP. And we've got wonderful professionals like clinical pharmacists and first contact physio and the like. So mental health workers, physician associates. We've got a broader multidisciplinary team. But I think one of the problems with the NHS in general is it's sort of thought about the service first, and it's thought about the ways of working first, rather than thinking initially about the different needs of the population. And Claire Fuller's Stocktake was the first time I'd seen a description of different models of care based on the different needs of the population. So to give you an example, there are quite a large group in the population, about 70% of which are generally well. And they have acute care needs of sore throats and coughs and chest pain and abdominal pain, and they need a prompt response, but not necessarily continuity of care. And on the other end of the spectrum, there's people with very complex needs, such as frailty, dementia, some people with learning disability, particularly if in combination with other conditions and disabilities, people with severe mental illness and physical health problems, who are very different from the first group I described. And they need much more continuity, much more proactive, preventative care. And when there is a crisis, they need a response from somebody who knows them really well. So I think Claire Fuller did a really good job of describing the different needs in the population and the need for a more nuanced response, a different response to the different needs that are out there.
Great, thank you. Now, this is a real emphasis on teams of teams rather than a single team handling everything. Now, could you explain to our listeners why this distinction is critical and what advantages it brings to patient care?
Yeah, so I think there will be a team of teams. There'll always be a team that oversees the whole population. I think that's important. However, what I tend to think of is three big models of care, three big teams, or three big areas where a team is required. So if I just run through those quickly, we've got preventative services, primary prevention, such as vaccination, screening, health checks, behaviour modification. That's a thing to do, and that requires a certain approach and a particular team of people. There's long-term condition management, where we manage people who have got diabetes or asthma or COPD or heart failure or a combination of condition. That requires a different approach again. We've got same-day demand or acute care, which requires some technology such as e-consultations, some telephone triage, some face-to-face appointments. Sometimes there's a hub either for e-consultations or triage or face-to-face appointments. And then finally, there's a team, often a very multidisciplinary integrated team, that is required to meet the needs of those with the most complex needs. So, for example, for people with frailty, you'd want some dementia nursing support, you'd want some care and support planning, you'd want some structured medication reviews, and that would require a different team of people doing different things. So as Claire described, I think the thinking goes, there are these different groups in the population with these different needs, and we need to create a team of people that's wrapped around those needs with the skills that are required to comprehensively meet the needs of that group or that particular need at the time. And then there's also a team that oversees all of that. And I think that is also important.
Now, to those listening, this may sound quite complicated to roll out across all the NHS, especially when you've got diverse populations, communities with different needs. Now, what are going to be some of the major challenges of implementing this model across the NHS?
I think that's a really good challenge, Andrew, and I recognise that it is complicated to an extent. It is different. I think historically, the NHS has gone about thinking about these sort of things in the wrong way. Mm-hmm. So I tend to think about 4 Fs when thinking about models of care. Historically, the NHS has started thinking about form and funding. And those things are important, but in my mind, they're not the place to start. The place to start is to think about a focus on people with complex needs, a focus on long-term conditions, a focus on acute care needs, etc., prevention, the other one I mentioned, and then to think about what are the functions that are required to meet those needs. So I tend to think about, first and foremost, focus, then functions, then funding, and only finally organisational form changes if required. So before we think about the structure and the funding of an integrated neighbourhood team, we need to think about what are the problems that we require an integrated neighbourhood team to tackle, which people need integrated care from different professionals and different organisations, and how do we deliver that integrated care. So I think the first thing to start in this, I accept, complex journey is the way we think about the challenge. So what I spend a lot of my time doing is to help, and I get a lot of satisfaction from, is helping people to think differently. Mm-hmm. So rather than thinking about a whole population and how we meet the needs of the whole population, let's start to break it down a little bit. And I would argue it's not that complex. I'm really only talking about 4 big models of care: primary prevention, long-term condition management with secondary prevention, tertiary prevention for those most at risk of escalation of care needs, and then same-day demand. So if we think, rather than as a single whole, we think about those four big challenges, those four big models of care, and think with an open mind how we deliver that within an area, a community. So I don't think it has to be too complex. And in fact, in a way, if you break things down, it makes it less complex. And then we need to think about probably not starting in all those areas at one time, but ask an area, well, what is your greatest challenge at the moment? Is it meeting same-day demand? Is it long-term condition management, et cetera, et cetera? And then start somewhere. Start with a focus on a priority area and start to engage with managers, clinicians, patients, and carers about how we can create an alternative way of working that's better for everybody.
Interesting point you talk about managers there. And my last question on this section before we move on to population health management is the people. Now you're moving towards a system here where you're playing on people's strengths and interests. However, you are going to get people who are accustomed to traditional roles, traditional structures. Bringing those people on board is going to be a challenge. So how do you plan to kind of ensure that professionals are kind of buying into this shift? Yet again, another shift, Stephen.
Well, we're talking about ways of working that is going to be better for patients and carers and the population as a whole. However, when you're engaging professionals, I think a reasonable place to start is their lived experience working as a professional. And this isn't going to work unless we, as people have said before, bring back the joy of work. So why not create a future where every GP doesn't, and I'm talking about GP because I am one, and it's hard to change things without clinical leaders and GPs on board if we're talking about primary care, which I think we are here. I think we can create an alternative future where not all GPs need to do a bit of everything.
Mm-hmm.
So at the moment, there's almost an acceptance that every GP has to do a bit of everything, a bit of acute care, a bit of face-to-face, a bit of telephone, a bit of e-consultation, a bit of long-term condition management, a bit of preventative work. Whereas in my experience, and validated by questionnaires that I've sent out, GPs have quite diverse interest. They have diverse interests, as do other professionals. So I think one way of creating an alternative future is to create a narrative where we show clinicians and other professionals that there's a future where they can do more of what they like, they can follow their interests and their expertise, and they can work in a team. And sometimes traditionally general practice can be quite a lonely experience, locked in your room, seeing and speaking to patients on the phone. We can create an alternative future where people can do more of what they like, more of what they're interested in, more of their expertise, and working with other like-minded professionals from other clinical backgrounds. And I think people will sign up to that, and there will always be flexibility.
Sure.
So we can be flexible in how that happens, but it starts with a simple premise that there's different groups in the population with different needs that need a different model of care. Let's enable people to work in those areas according to their expertise and their preferences.
I mentioned population health management rolls off the tongue. You are embedded into it, but just briefly, just before we go into more questions around population health management, can you just distinguish for our listeners the difference between public health and population health management?
Thank you, Andrew. I think that's a really important distinction because people, in my experience, do conflate the two. And they are very different. And I think the distinction is quite simple. Public health seeks to improve the health and well-being of a whole population. Population health management seeks to improve the health and well-being of segments or cohorts, groups within the population, one at a time. So just to bring that to life a little bit more, public health is about things like ensuring smoke-free public places, access to good food, to clean water, to green spaces, to education, to employment, the sorts of things that will improve the health and well-being of everybody. Population health management, by identifying different groups within the population, will seek to improve, partly but not exclusively through the delivery of care, improve the health of people with diabetes, people with multimorbidity, people with frailty, people with learning disability. So it does seek to improve the health of the whole population, but through interventions at a cohort and individual level, rather than public health. Most of the interventions in public health is at a whole population, whole community level. So I hope that explains the difference.
That's very clear for our listeners. So therefore, it would infer that you don't need a good level of data here to identify those cohort of patients when it comes to population health management. So could you expand a little bit on how data and analytics can be used to tailor care at a neighborhood level, for example?
Okay, no, great question. And again, a distinction. Public health data tends to talk about the health needs of a whole population and the priorities. And that's really important. And it sort of tells you the what are people suffering from, what are people dying from, but it doesn't tell you who, because the data isn't at an individual level in a way that people can be identified. So what population health management data allows you to do is to understand the health needs at an individual level. So not only who has diabetes and how old are they and what's their gender and their ethnicity, etc., but what other conditions do they have? So do they have just diabetes? Often not. Do they have diabetes with cardiovascular disease and hypertension and obesity? Quite possibly. So population health management data is patient level, and ideally we would have linked data. So we know across primary care, community care, mental health care, hospital care, mental health care, what needs people have and what healthcare and social care they're consuming. And then we can begin to group people in meaningful ways. So we'll understand within a community who has multimorbidity, who has frailty, who has no long-term conditions, but smokes, is obese, has pre-diabetes. So not just thinking about individual risk factors, but multiple risk factors for future disease. And then we can target preventative care, we can target long-term condition management, we can target holistic care for people with complex needs.
So on the subject of data, I want to jump to a question not necessarily about the patients, but more so about the team. So what metrics or outcomes can we use to measure the success of these neighborhood teams? And what does success look like for patients with this new model, healthcare providers and the NHS as a whole?
So I think one of the advantages of population health management is it not only allows you to identify groups of people with priority health needs and wrap a model of care around them with the right care functions and the right team, it enables you to monitor outcomes at a cohort level. So we can use the outcomes that matter to people. If you have a learning disability, what are the outcomes that you wish to have? And I've got some experience in this area with my daughter who has a learning disability, but it's about meaningful activities in the day. It's about employment opportunities. It's about being as independent as you possibly can be. For people with complex needs at the end of life, frail, elderly, end of life, again, it's about independence. It's about maximizing time at home with your family. It's about avoiding unnecessary hospital admissions. So population health management enables us, when we talk about outcomes, to use the outcomes that matter to people and to the system. So the system wants people with learning disability in work, and woefully low numbers currently are something like 5%. It allows us to focus on avoidable hospital admissions for the frail elderly. It allows people with behaviours that put them at high risk of hospital admission to get non-judgmental supportive care to manage all their lifestyle challenges at the same time. So by doing that, we're measuring the right outcomes, and we're giving us a chance of success because we're measuring the outcomes on the cohort that we're focusing on, and we're not expecting to change the health of the whole population in one go.
If and when this model goes wide across the NHS, I'm very interested to see what your thoughts are about the scalability of this model in the private market here in the UK, but also how can this model be used internationally as a penultimate question, Stephen?
When you say the private market, do you mean people who pay for their healthcare services?
Correct.
I mean, I think sometimes retail and the private market can understand this a little bit more than the NHS does, because I suppose the private market is perhaps closer to customer experience, closer to thinking about segmenting their customer base and their user base, whilst recognizing that the private healthcare sector tends to deal more with episodic care than ongoing care of long-term conditions. I think in a way it doesn't matter who is providing services. Whoever those providers are need to be very mindful of the different types of people in their community, the different needs that they have, thinking about them holistically, not as individual conditions, but an individual with a certain set of challenges, and then wrapping a more holistic, more proactive model of care around them. And in that regard, maybe the private sector isn't as used to that as the NHS is, because the NHS is used to being there, from cradle to grave, and being there for all care needs. But I think even in the private sector, even if we're more talking about a focus more on long-term conditions and the episodic care and elective care that people need, they're still different to other patients, and they still require more person-centered, more holistic, more ongoing care. So I think everybody has something to learn from this model. And if the private sector has the data that can enable this more personalised model, this more nuanced approach to care delivery, then I'm sure the private sector would want to embrace population health management approaches even if the denominator population that they're looking at isn't the whole population, it's just the people who are maybe on their particular insurance scheme or under their care.
And a final question. Now, listening to this will be healthcare professionals who are interested in this model. So in terms of what would, last question, your advice on, I'll start again. Finally, what would be your advice to those systems who are listening and having challenges in implementing this new strategy, Stephen?
I think what I would say is get around a table or in a room with a broad range of individuals who have a stake in this. So citizens, patients, carers, clinicians, managers, get in a room in your neighborhood, your place, whatever the scale is, and start to talk about the different challenges in your neighborhood, not at a disease level, but as a person, at a person level. So rather than talking about the challenge of asthma or diabetes or respiratory disease, just bring it up a level and start to talk more about the holistic needs of large segments of the population. Working age adults with complex needs, frail elderly, young people who are well but have an acute care need, people with multi-morbidity, and then start to prioritize which are the areas of unmet need, which are the areas where the local workforce is struggling to meet the needs of that population. And let's start to imagine what an alternative model of care could look like. And how could that be better for the population, the citizens, the patients, the carers, but just as importantly for the professionals working in that area across all sectors. And I think it's entirely possible, so long as we have a focus, we don't try to do everything at once, we get the right level of granularity in our prioritization right. So from pathways to big programs of care around a population segment. And let's start firstly to change the way we think about the problems in the way I've just alluded to. And then let's start somewhere and make a difference and accept it's not going to be perfect. We can't do everything at once, but we can start on that journey.
Wonderful, Stephen. Stephen, it's been great having you on MedTalk this episode, and we look forward to inviting you at another stage in the future. Thank you very much.
Thank you, Andrew. Nice to talk to you. Bye, everyone.
Bye. If you enjoyed today's episode, subscribe to our channel and share with someone who might find it useful. You can find all the resources we talked about today in the show notes on LinkedIn, X, TikTok, and YouTube. Whenever and wherever you're listening to this episode, thank you for tuning in. Let's keep the curiosity alive, and together, let's work towards a better healthcare for everyone. Goodbye.